sexual violence of men goes on in conflict. The brutality of war, you see. Rape was used with impunity in the Rwandan genocide, in the Bosnian war. Now in Ukraine, they're talking about it. In Palestine, Sudan, it's quite horrific. Eastern Congo is quite horrific. Where do people go? It's women and children predominantly. They don't want to be displaced. They don't want to live in like a tent city for years to come. They were all working in Ukraine. They were accountants, lawyers, social workers, engineers. They come into this country, they have very limited English. This traveling exhibition of photographs taken by the participants itself. It's stories through photos. Children have been in long-term care. So they have had mental health impacts. The care burden is with the mother mostly. If you have a child who's autistic, if you have a child with cerebral palsy, the child is there forever. There's always this phase in teenage years to experiment. In a small number of people, this becomes an addiction. We have problems when it comes to addiction to prescription drugs.
Yeah.
So you have addictions to
Before we get started, please subscribe so that you never miss an episode of our cutting-edge contemporary conversations. Thank you. Welcome, Jaya. How are you?
I'm well. Thank you very much for inviting me today.
Thank you for your time today. You have a fairly academic and broad experience across geographies. And I could ask you to elaborate on your background and your experience.
Yes. So, as I said, my name is Jaya Dantas, and currently I'm Professor of International Health at the Curtin School of Population Health, as well as the Dean International in the Faculty of Health Sciences. But I'm originally from India. I was born in Mumbai, India, and lived there to my early 20s. I did my master's degree and was a food scientist for a period of time when I worked at a women's university in Mumbai. But at the same time, I was aware of many community issues, and I was involved with the community even in India through my church and my wider community. So issues to do with women's health, issues to do with family and domestic violence, issues to do with the social determinants of health and health equity was something that always affected me in some ways. I am in higher education, and I've always been in higher education. In 1990, I moved to Africa, and I lived in Africa for the next 10 years across 3 different countries in East and Central Africa. So I was in Kenya for nearly 4 years, I was in Uganda for 4 years, and I was in Rwanda for 3 years. I was in Africa at really critical times in history. If you remember the 90s, then you have 3 events that took place in Africa that actually impacted the world. The first was another pandemic, the HIV pandemic in sub-Saharan Africa. So I was right there in Kenya and Uganda when the pandemic was taking hold and when it became a full-blown pandemic in Uganda. I was there when apartheid ended in South Africa, in Uganda, and at that time, in 1994 and 1995, we had a contingent of the African National Congress in Uganda, and we saw that. So that was the end of apartheid. The third event, which was a little more harsher and difficult event, was the genocide in Rwanda in 1994. I was in neighboring Uganda, and then 3 years after the genocide, I went to help in the rebuilding of the education system. So my interest in all of these emerged and continued. And in Uganda and Rwanda, both were post-conflict settings. Uganda had 2 decades of civil conflict with some brutal leaders like Milton Obote and Idi Amin. When the South Asians were given just 90 days to leave Uganda in 1972, and then only in 1994, and from 1986, there was a relative peace. But there was a civil conflict of nearly 2 decades from 1972 that really impacted the country. I was involved with the education reconstruction in Uganda and in Rwanda. And it actually gave me a really strong foundation in what it is like to rebuild systems which have been decimated by conflict, where resources are limited, both human and financial resources. But people are resilient. I also witnessed mass refugee movements when I was there, and that was a new interest that emerged when I was there, and that was in refugee health and refugee movements and refugee education. So I continued that when I came to Australia in 1999. I've continued my interest in global health. So since 1999, I do research in global health and have been to different countries looking at different populations.
Wow. Very, very diverse experience in terms of the education side of it and understanding on health side of it. Can you elaborate in terms of if you can draw some parallel between while working at a women's university in Mumbai and also exploring multiple countries within African subcontinent, that what are similarities in terms of health or health challenges people were facing?
So in India, we have disparities in health. So although I was in Mumbai, I was in a place where women could have an education. And this was a women's university that was started, one of the first women's universities where they really wanted to empower women to have an education and actually higher education. It's not enough to have a primary education. It's not enough for secondary education, but to have a tertiary education so that then they can be empowered and join the workforce. So I found that. But there are disparities in health, even in India, that I saw, because I studied to be a food scientist and a food technologist. And what I realized is the disparities in women's health. So India bears the burden of women's anemia in the world. Lots of Indian women are anemic. Women, the girl child in the first 1,000 days, that is first 3 years, might not have adequate nutrition. And that means it results in stunting throughout their lifespan. It gives rise to low birth weight babies to those mothers. At the same time, with women's health, at that time, I'm talking about late 80s and early 90s. At that time, still there were cultural issues that were there. India is still quite a patriarchal society. So for women, even though in Mumbai, women worked, at the same time, they traveled long distances for work. They had challenges when they had to manage work and house and children. We still heard about dowry debts. We still heard about sex-selective abortions in India. The HIV pandemic was also starting. It started in the United States, where it was very much homosexual, whereas in Africa it was heterosexual between partners. And in South Asia and Southeast Asia, in countries like Thailand, Indonesia, Philippines, India, it was also heterosexual. So I learned about all these issues. And one of the things that I saw is like dowry debts, the impacts of dowry, family and domestic violence issues, and often not enough legal safeguards for women to be able to actually leave a challenging family situation for the sake of the children, for economic reasons or financial reasons. So that was there. In Africa, it was totally different. In Kenya, what I found was, what was confronting for me was the huge number of street children. Like, you do see poverty in India because you do have the slums in the big cities. You have that disparity. But everyone tries to work. The children are with the parents in some ways, even in the poor households. But here, these children had been abandoned. They were in the streets, and that was quite confronting. The violence, the level of violence in many of the African countries was significantly higher than what I had experienced in a city like Mumbai. At that time, police still had batons, they didn't have guns, whereas there you saw soldiers on the streets, you saw the police, and you also saw the challenges that come with severe disparities. So you had security guards, you had dogs, and all of that. That was what I saw in Kenya. But it was also formative years for me. My son was born in Kenya, and at the same time, I moved from higher education into primary education because it was opportunistic. I was going to have a baby. I was there. There was an international school. There was a malaria research center. And I got this wonderful opportunity for 2.5 years. That was excellent. So I met people from all over the world. There was a USAID scientist who were doing malarial research. Again, I was exposed to malaria. I was exposed to HIV, which I was not in a big way in India. Although I was exposed to things like, Hep A, like jaundice, and you were exposed to tuberculosis. That comes with the challenges, circumstances that people live in. And from Kenya, I moved to Uganda. And Uganda, again, there was a different level of violence because people had lived with conflict. So you had, again, you had the street children, you had HIV, you had soldiers on the streets. And so you saw guns at very close level, which I had not been exposed to. So then I was given the opportunity to lead a school and rehabilitate a school that had closed down during Idi Amin's time. And that was an excellent opportunity for me, because here I was a young woman, but by then I was working in 3 countries.
Yes.
So I had that experience. I had a master's degree. I was confident with English language, and I learned a lot. So I learned that we had to change the policies because of HIV, the high rates of HIV when children were injured. There was high rates of mother-to-child transmission, which was new to me. I also found that within this setting, you had lots of single mothers. It was common for someone to have a child and then bring up the child alone, which was unusual for me coming from India and from a conservative Catholic household in some ways. But it was a wonderful experience because I worked with local Ugandans. I was involved in a large Aga Khan development project, which was funded by the European Union. And we looked at a school improvement program so it used a school improvement model, which was a cascade model. So you actually use one school as a model school, and then you grow satellite schools that become model schools. You establish a library, you train trainers and teachers who then go out and train the others. So that was a very good experience. And I worked with a wonderful mentor, and she became a family friend. She was from the UK, but originally from Tanzania, and a Tanzanian Indian. And I worked closely with her and learned from her. So we're still friends. She went back and retired in London. We're still friends. And now it's so much more easier, with WhatsApp to keep in touch. So she was a good mentor to me. And that's when I realized that it's so important to have good mentors in life whom you can talk to at any time. The countries do not matter. The borders do not matter now. Then I moved to Rwanda, and I had this fantastic opportunity to work closely with the government to establish a school. The school's called Green Hills Academy, and now it's a bilingual school, English and French, and it's an IB school. So I was there setting it up at that time when it was really challenging after the genocide in Rwanda. It was a nation that had borne the brunt of the genocide. A lot of people had been killed, especially it was the genocide against the Tutsis. In 3 months, between 800,000 to 1 million lost their lives. It caused the largest mass movement of people in a shortest period of time. In 3 months, about 2 million. So I learned what it was, both in Uganda and Rwanda, to be resilient when there's so much adversity, when you've seen death at close quarters, when you've seen family disappear, when you have seen family injured, killed in front of you, you still have to continue living. So I worked with teachers who had hidden in forest, who had experienced the genocide, but who were there now rebuilding their country. And some of them were still grieving because they didn't know where family members were. And people need to grieve and need closure. And that's what I also learned about. So learning about all these things gave me a unique sense of perspective. So when I was in Uganda, my daughter was born in Uganda. So I had one child in Kenya and one child in Uganda. And now when I reflect, I just think that how did I have a child in Uganda at the height of the HIV pandemic? Well, she's a young woman living in Melbourne now, and she was impacted by the COVID pandemic when in Melbourne. So that was interesting. And then from Rwanda, I had started a PhD when in Rwanda at Curtin. So you develop friendships. And in Kenya, I developed a friendship with a friend who's now also a professor at Curtin. So she was Australian, West Australian. She said, oh, if you want to do a PhD, Jaya, you should come to Curtin. I'd never heard of Curtin University. I'd never heard of this. Although I had a sister living in Sydney, I chose to come to Curtin University, but I chose to come because of this long friendship that I've had with another fellow teacher, a West Australian. And that was wonderful. So friendships last, and the friendships that I've built over years have lasted decades across countries. Then I came here, and my PhD was on Rwanda, post-genocide reconstruction, after genocide, how people rebuild, and the dimensions of poverty, the dimensions of resilience, the dimensions of the social determinants. And I came back, and I finished my PhD, and I was offered a job at a Center for International Health at Curtin, a part-time job, which suited me because my children were very young at that time. And I got funding from the university to do a small project in East Timor, in Timor-Leste. And I thought, this is another post-conflict country. So I've done Rwanda, I've done Uganda, I've been Kenya, which is not post-conflict as such, but now I'm going to Timor-Leste. And at that time, just before going to Timor-Leste, I also got an opportunity to go to the Balkans, to Kosovo, and where the conflict with Serbia was going on in the Balkans. So I spent some time in Kosovo. The challenge there was the language. They spoke Serbian and not English, so it was more difficult. But I spent 3 weeks visiting the schools, seeing the education system, seeing the universities, how challenging it was for them also to live in this duality. They wanted independence. They were the Kosovars are Muslims in there, but the Serbians are Christians. So all of these complexities that were there. And then I went to East Timor, and I did a project there on migration and mobility and health, because there they had a referendum, and they had actually basically said they didn't want to be part of Indonesia. They wanted to be a free country. But one of the things they did is they chose Portuguese. They were a Portuguese colony before. So then Brazil and Portugal came forward to help them rebuild. So I did this large study with the International Organization for Migration. And whilst I was there, I took 2 of my master's students with me to do the study. Wow. And it was a wonderful experience. And we saw this advertisement from UNICEF for a study in Sri Lanka, in the conflict areas of Sri Lanka, looking at child soldiers. And I said, we are in East Timor. We are looking at a different region, but they want us to we were looking at vulnerabilities and vulnerability assessment. And they wanted us to do a vulnerability assessment with child soldiers in the conflict areas of Sri Lanka. And we just applied. Sitting in East Timor, we applied for this project, and we got it. So my next thing was going to the conflict areas of Sri Lanka. I went, and that to me was really interesting, because they had this parallel nation state within a nation state, with the LTTE at that time. And I visited 6 of the 8 districts. So I visited Kilinochchi, the headquarters, Mulaitivu, Vavonia, and Batikloa, as well as I visited Ampara and Manar. I didn't go to Jaffna and I didn't go to Trincomalee because the situation started deteriorating there. They were having the peace talks with Norway. And what was interesting for me in all of this, when I talk to people, all people want is peace.
Yeah.
They just want peace. They want to live with their families. They say that we want this. The moment there is peace, there's a wonderful commentary on life. The cafe is open. People sit on the sidewalks, have their cups of tea, coffee, beer. They have their food everywhere. Everywhere I've gone, when there's peace, people have that. People want to be out and about wherever. But peace, when peace is not there, and when there's conflict and war, it erodes that. And when I talk to women in Sri Lanka, there were villages which had no men. So they were war widows. They didn't know what had happened to their husbands. They had disappeared. Were they in prison? Were they dead? And they said, but we have to continue living. And they said, you tell us to look after our children, no problem. You tell us to actually give birth, no problem. Help in birthing. But peace is something that we want and we'd like to have.
And as we are talking, there are multiple conflict zones across the world. And because your research and knowledge is in conflict zones and post-conflict zones and understanding health equities in different demographics of people, what do you think is happening or in your research? What's your understanding between, in the Ukraine and Russia, that conflict zone, and in Palestine, Gaza and Israel conflict area? What are the long-term health effects and impacts, and how do you define health equities in those zones?
So one of the things that where there is protracted conflict, so there's been protracted conflict in many countries, Somalia, Sudan, South Sudan, Afghanistan, Israel-Palestine has been ongoing, Syria. So all of these protracted conflicts leads to significant trauma in the population. So there are mental health impacts that can never be measured. They can never be measured because they'll carry the scars of the trauma from childhood to adulthood. Like people lose their jobs, they lose their homes, and we can see that happening now in the current conflicts in Ukraine, 4th year, in Gaza, going on to the 2nd year. You've seen that in Afghanistan, for decades, in Somalia, decades. South Sudan and Sudan has erupted now horrifically. I look at conflicts around the world. So Haiti is in very bad shape. There are ongoing 20 conflicts. Some are spoken about more, but some less. But all of these conflicts have huge human impacts. One is mental health. Second, sexual violence and conflict. Yes, sexual violence of women, but even sexual violence of men goes on in conflict. Third, the brutality of war, you see. So people go into war who are not soldiers. They're not actually trained soldiers. But here they're fighting a war as it's happening in Ukraine, as it's happening in other countries also. People actually fighting when they're actually not soldiers. And this has implications because you can be injured, you could lose a limb, or you could die. Then one thing we have seen is population movements. Where do people go? We saw population movements. I talked about the Rwandan conflict. We saw what happened in Bosnia. We saw what happened in Ukraine. It's women and children predominantly, because often men stay behind to fight or they're not allowed to leave. But where do people actually go? They don't want to be displaced. They don't want to live in like a tent city for years to come, as it's there in certain camps in Syria, in certain places in Sudan. And then at the same time, pregnant mothers, the elderly, those who are disabled, and children are extremely vulnerable. You can't have immunization in these countries. And I look, so from a health equity point of view, we have a resurgence of measles. We have a resurgence of polio. Why? Because of conflict and not being able to vaccinate children or mothers. So this becomes a big problem. The most vulnerable face terrible situations, because what happens if you're disabled? But what happens if you're elderly and you lose your home? We have seen that in Ukraine, where the elderly actually didn't want to leave their country. But now certain parts of Ukraine have gone into Russian hands. But these people had lived there all their life. And now suddenly, where do they go? This is their home. You know? So those complexities are there. So from a health perspective, there are multiple layers that impact the populations that are impacted by war. And so I actually just completed a project with Ukrainian displaced people in WA. I had funding from Healthway and Lottery West for that, you know, and it's a traveling exhibition that's going around in the libraries and in the universities. And basically, they talk about this. See, they were all working in Ukraine. They were accountants, lawyers, social workers, engineers, etc. They come into this country, they have very limited English. So when they have very limited English, it's problematic, because then they actually can't work in their professions. They have to study English to a certain level, professional level, which is also difficult because it means time. And at the same time, they've left family members back home. So this traveling exhibition of photographs taken by the participants itself. So we had participants of various age groups who took part in the Photo Voice project. So actually, it's stories through photos that I do also. That's one of the methods that I use, called Photo Voice. So I've done multiple projects using photographs by refugees who are fleeing war zones and coming in here. The other thing is sexual violence. So rape was used with impunity in the Rwandan genocide, in the Bosnian War. Now in Ukraine, they're talking about it. In Palestine, Sudan, it's quite horrific. Eastern Congo, it's quite horrific. So it becomes a brutal aspect of rape where women have to live with the scars. You need, in extreme cases, you need reconstructive surgery. So you need skilled surgeons to do that. And that is a problem. In Eastern Congo, it's actually brutal rape that's going on and has gone on for decades. So these are the challenges that you have from a health perspective. And the health system is in chaos. You know, the doctors have fled. There are not enough doctors. Medicine Sans Frontières is there. But again, the doctors, you know, dealing with the trauma and with very poor resources and field hospitals becomes very challenging.
From an Australian context point of view, what are the trends you are seeing in terms of within Australian demographics? If you can lay in a bit of understanding for young Australians, for Australians with disabilities, elderly Australians, and then young people, what are the trends in terms of health and healthcare you are witnessing?
So when you look at Australia's healthcare as a whole, it's one of the best in the world. You know, we do have a fully functioning health system. We have the Medicare, and because of Medicare, you can go into a hospital and be treated. If you have an accident, you will get trauma care, you'll have surgery. If you are a cancer patient, you'll get cancer care. So all that does happen. But Medicare is not actually free, because you pay 2% of your wage at all levels. So there is a Medicare levy that is given. And at the same time, there are gap payments that have gone on. Yes, there are very few GPs now who bulk bill. In most cases, you have to pay a gap payment. Now, I have done multiple studies recently, and that's why I can actually talk to you with that. So one was this Ukrainian one with refugee populations. So when it comes to refugee trauma, I get constantly asked, we need psychologists who are trained in trauma, you know, war trauma or protracted trauma, to deal with our refugee populations. You know, that's a need. But we have a shortage of psychologists across the board. So that becomes a challenge. So that's one genuine challenge that is there, that when refugees come in, they have the trauma, mental health trauma that comes from living in a war situation, that comes with displacement, but there could also be injury. Many a times in war-torn societies, men get beaten. You know, they get beaten. So they might have fractures that have not healed medically. So that leads to pain. And so management of pain also is needed, and an understanding of that is needed. And I've had many, when we have done studies with South Sudanese in Melbourne and all talk about this aspect too. Then the other study that we have done is youth at risk. So to prevent youth from becoming criminals, they need strong role models and a strong system of support in adolescence. But you also have you have a large number of youth that are falling through the cracks. So basically you have youth in the foster care system. You have refugee young people. You have people from indigenous populations. Now, another thing that I wanted to share is from 2002, I also became a foster carer. So apart from my 2 children, I've looked after 5 other children. So basically, these children have been in long-term care. So they have had mental health impacts. But they have been in my long-term care. And one thing that I shared and have always supported is the value of education, the uncontested value of education. And I have supported them even after they have turned 18 because I've had the capacity to do so. I can do so. I'm financially able to do so. Not many foster parents can do that. I was fostering while working full-time. So I take kids who are not babies, who are in school. They will definitely have mental health issues because of their backgrounds, but they don't have huge behavioral issues. But youth at risk is, there are different levels. So, children born to parents who have had alcohol during pregnancy have fetal alcohol syndrome disorder, and they'll always have developmental disorders throughout life. The second thing is children who have had high rates of violence, growing up in a violent household, carry that burden too. Then you have children in their teenage years, for some reason or the other, get addicted to substances. It could be alcohol, it could be drugs, and then they spiral into a psychosis. Then you have others, because of cultural issues and honor-based issues. There's forced marriage, there's arranged marriage, young, early marriage, and then there are issues of modern slavery with young populations. So all of this still goes on within Australia. And how do you protect our youth in this social media age, where you can have so much of information, but also misinformation? And then with the elderly, we have a population that's living longer. Even in our communities, they're living longer. My mother lived with me for 14 years, so she lived with me, so I know, it is. But as you grow older, you have things like arthritis, you have conditions like osteoporosis, you have other conditions, and how do you actually live a good, healthy life as a senior in some ways? But then there's also intergenerational caring that goes on. So when Mum lived with me, I had an elderly mother, and I had children, and I had foster children, all living in one household. So that was good in many ways. But I think it also taught me to be strong and manage a larger family in some ways. But then when the care burden increases is when there is disability associated with an elderly parent or a child. So an elderly parent has dementia, or Alzheimer's, or an elderly parent has injury, falls and breaks a hip or something, and needs extended care, or has cancer, and the burden often falls on the caregiver. And somehow a country like Australia doesn't do it as well as it can. So although the National Disability Insurance Scheme was set up, there's ACAT and all of that, somehow there are gaps that need to be met. So across the spectrum, intergenerationally, starting from early childhood care and development is a big issue here. So women, if you've got a full-time job, when you have a child, then you think, do I go back to work? Do I go back to work part-time? How much is childcare? How much will I get with a government rebate? And I think we have not done that well. We have not done that well. And I hope our early childhood minister would look at that aspect, because what we have is a system where childcare is exorbitantly expensive, but there are childcare providers that are becoming extremely rich. And See, I have a problem with service-related industries like childcare, like education, like aged care. They shouldn't be profit-making.
You're right. Yeah.
They shouldn't. But they are, because people are becoming wealthy, businesses are becoming wealthy, and then there are businesses. And you try to find out, who is the owner of this business or who is the owner, and you can't. It's very difficult to find that. So these are the things that I see in the Australian landscape.
I would like you to a bit more elaborate on the early childhood space. In different settings, federally you call it ECEC, Early Childhood Education and Care.
Yes.
And some organizations treat the childcare business as more of an education business, and then some organization would assume that as a care business. And then how do you draw the line? What do you think for the young people, it's more of a care sector, or is it more of an education sector? So how do you draw the line, or is it a mix of both?
Actually, from when the child could be 4 months to 6 months and is put into care, that is early childhood. That's an infant who needs care. And then up to about 3 years, that phase is where it's childcare. But when I was in Uganda, I had worked closely with a program, and it was called ECCD, Early Childhood Care and Development. And then from 4, they can go to kindy. But what I found is children were ready from the time they were 3 years to go to a play school for 3 hours. And I saw these models that were there in Uganda, where the child was brought for 3 hours, and they were there, they were in a setting, they had morning tea, they played. And at 12 or 12:30, they were picked up and taken home. But because of this situation, 3 hours when they had done that, they were quite tired. So they went to have their lunch and have a sleep. And it worked well, but it was a different setting. Whereas here, it can be long days for the mother if the mother is working. Once they are in school, it's but the school system finishes at 3. So after 3, there's after-school care that is required. And then there are the school holidays, so there's vacation care. So all that comes under care. Someone has to look after the child if the mother wants to work, if the primary carer wants to work.
And I'm very keen to understand, is there any work done or research done for young people? Because the reality of life in Australia is, yes, part of the proportion of the families will be broken families, or two family households. As mother and the father being raising the child in different ways. How has 2 family household versus single family households impacted on the anxiety levels, mental health of these young people growing up? And in a way, is it carrying some form of conflict or anxiety as they're growing up on their mental health?
One thing I would say is, when it's a single household, if things are good in the household, where both the mother and the father have a wonderful relationship, share in the care and duties, then it's fine. But in households where there's only one primary carer, where they see that either the mother doing everything for the child, also working and all of that, then it's a different model. They see that. But where there are split households, some parents co-parent very well. So where there's been a marriage breakdown, but they have co-parented really well, there's an excellent understanding. They say, okay, I will look after the child 1 week, you look after the child the other week, we'll also share the care during the holidays. If there's that clear understanding, and I've seen it in some cases, it works very well. They share everything, but when they have to share equally, then both the parents are able to come to that understanding, and at the same time, they contribute equally. But in many cases where the one parent might get the child only for a shorter period of time. So in cases where they might see the child for, say, 2 nights or 3 nights every fortnight, then it's different. So then the child is with the primary carer with the mother in most cases, and then the mother disciplines the child and everything. Whereas if they're taken by the father only for a long weekend, then they're seen differently, they're perceived differently.
Yeah.
So that's a different model where they'll grow up. But you see, what I always feel is when children have safety, they have security, and their needs are met, it's fine. But when it's an acrimonious separation, where the parents are constantly fighting, then it has impacts. Because it has impacts on the mother, it has impacts on the father, and it has impacts on the child. It goes without saying when it's an acrimonious separation. So that's where I've seen it works really well when they co-parent very well. And they've said, yes, whatever it is, we'll do what is best for the children. So they keep the children in mind. Then there is one where a parent might not care and say that, okay, you look after, I'm just taking the child at this time. Then when there's difficulty in the relationship, and in some cases, the father says, that's fine, you can take the child, I'm not going to pay anything, I don't want to even see the child or see the child only in the holidays. So there are different sorts of scenarios in some ways that have impacts.
I think, is there an observation or more research done in terms of, abuse of substance abuse happening at a younger age? People at the age when people start abusing drugs or, using drugs of some form has changed, and what are the impacts again on the health equities?
I would say that there's always this phase in teenage years to experiment. So they experiment. They experiment with drugs, they experiment with alcohol, they experiment with marijuana, smoking marijuana, they experiment with smoking. Now it's vaping. So in a small number of people, this becomes an addiction and unmanageable. And when that happens, then it's problematic. Most people manage it. They manage it. They experiment and say, I don't want to touch drugs. Or they'll say, I'll just smoke weed sometimes. Or they'll say, I don't want to smoke anything. No vaping, no smoking, no anything, or not zero tolerance for drugs also. Or the occasional drink. They'll have the occasional drink. But what has happened now is that we have problems when it comes to addiction to prescription drugs. So you have addictions to oxycodones, benzodiazepines, to Valium, to Xanax. These are prescription drugs, but people are getting addicted to that. So someone's prescribing those for them. Now we have medicinal cannabis. We have to really be careful and see that whoever is prescribing understands the health of the person. So these are challenges we face. And when I look at post-conflict societies, I also look at human trafficking, arms trafficking, drug trafficking. These are the big three money earners in the world, illegal money earners. So you have arms, because someone is giving the arms to these rebel armies throughout the world, to say, you have various ones, I won't name them, but we know many of them around the world, they get arms. So arms trafficking goes on. We have newer arms being manufactured. What's happening to the old arms? They are being sold somewhere. So that's something. Then you have drug trafficking. So there's this whole, you could say, a global network, supply chain network of illegal drugs that they find ways. You find people carrying drugs and being caught. That's just small. That's small. You have large amounts going around the world. And in countries where there's absolutely strict penalty, that becomes difficult. Say like Singapore or Vietnam or Indonesia, it's the death penalty. You will be sentenced to death if they find you with drugs, whatever the amount. So then that acts as a deterrent. But for others, when they know that you might have a fine or 8 years in prison and then you might come out, people try. So there's a huge volume of drugs all around the world. You have fentanyl, ketamine, you have manufacturing units in various countries where illegal drugs are being manufactured and going around. This is a problem, because as long as that is not stopped, you'll have drugs that will be peddled, and you'll have addicts that will grow out of that, who then have psychotic episodes and fall through the system. And then there's the human trafficking, where people are trafficked throughout the world, and we know that happens because everyone is looking for a way out. You find it difficult to live in certain countries. You want a way out of countries which have brutal regimes. I think where Afghanistan has stopped the higher education of women after the age of 12. That, to me, who values education, is so difficult to understand that if I was a woman, a young girl or a woman in Afghanistan, I would want to leave because it's so hard there. I won't get an opportunity for an education. Or for that matter, you would be growing up in Eritrea, say, or growing up in Libya, or growing up in Haiti, or growing up in El Salvador, where it's so brutal and where there's not enough work for young people, you'd want to leave. And that is that's where the traffickers come in. They know that there are people who want to leave, young people who want to leave. So that makes it undocumented people being trafficked.
From a point of view of drug rehabilitation programs, people who are falling through the cracks and continuing the usage of, drugs in many ways and forms, whether they're prescriptive or, bought off the street. When somebody goes to a drug rehab program and they are on a chemical, and how does the rehab program works? And if you are replacing a form of chemical compound to another chemical compound, which is of a lower intensity, but similar family of chemical compounds. So how is that the right model of drug rehab, or is there other models tested in the world?
There are various models tested in the world. So there would be a model where it's the methadone program. So people who are addicts then go on a methadone program, and then they are tapered off the drug. Addiction, especially drug addiction, is really, really difficult. We know that even with alcohol. We've seen alcoholics, it's very difficult for them to give up. Then there's another model, like centers like Palmerston, where a person goes for 6 to 9 months. And actually, he's rehabilitated. They have therapy within that group therapy. They have mentors. People who are overcoming addiction need extreme support for a long period of time. So they'll need a mentor. They'll need family to support them. But they have burned their bridges with their families. Families are too scared. The families feel that they might steal. Families feel that this relationship of abuse and will go on. So basically, it becomes really challenging. So that's another model where they actually have. When a person decides that I need to do this for myself, so I can be back with my family, I can look after my children are now in care, I can look after, then that is the time when they will seek care. They will seek, but they will need that support. It's not impossible, but it's really hard. And I think our system is not doing it very well at the moment.
On a conclusion question, in terms of healthcare equities between men and women in Australia, what do you see broader trends coming out and in your research?
So one of the research that I'm doing now is the Shakti Project. So the Shakti Project is looking at family and domestic violence within culturally and linguistically diverse communities, especially refugee and migrant communities. And we were looking at post-COVID, what happened. So I've interviewed a cross-section of women impacted by domestic violence, and I've interviewed service providers. So we know that family and domestic violence impacts both men and women, but a larger proportion of women are impacted. And it is an area that is actually not considered or funded appropriately at all levels. There's psychological impacts, there's legal impacts, there's financial impacts, there's child support impacts. So all of these impacts are not understood, and it can be long drawn. So that's an area that it's inequitable, and it impacts the women substantially from the research that I've done. It impacts a small amount of men, but both. How do you work with perpetrators? How do you work with men? How do you educate them so that they can share why is it that this happened, this violence happened? So that's one area. The other area is also the area of care burden. Care burden. So from a health perspective, if you have a child who's autistic, if you have a child with cerebral palsy, the child is there forever. And the care burden is with the mother, mostly with the mother. If you have elderly parents, then you have to look after the parents. So that's where I feel there are various issues. Another area is in the postnatal period, and not having enough support in that postnatal period when you've given birth to about 4 to 6 months, where a woman might be alone without family here. They might not have enough support, and at the same time, it could be a difficult child, who might not be feeding properly, who might not be sleeping properly. So these are the areas that I see in terms of it. Then the healthcare system. So when we look at the system, we may look at systemic issues of cultural issues, racism issues within the health system. But this comes down to education of the clinicians, the service providers, as well as the communities themselves. The indigenous communities have been quite vocal about racism amongst them, for them, in the health system. And even certain migrant groups, who are visibly different, say that they also feel this difference when it comes to health providers and how they act with them.
Well, thank you for sharing your stories and a bit more research to back that up, and congrats on the travel you have done across post-conflict. Not congrats, but very strong person you are. And thank you for your time today. Thanks a lot.
No, thank you for inviting me. I didn't realize that it would be like this. I just thought I'm doing a podcast without being photographed in some ways. It was not a video podcast, but maybe an audio podcast.
Okay.
Because I've done the audio podcast before. So I was just pleasantly surprised. I hope it'll be okay.
It'll be fine. Thank you, ma'am. Thanks a lot.
You're welcome.